Hello everybody. Today's topic of discussion is severe dengue in ICU. Dengue transmitted by the bite of infected Aedes mosquito, and it is the most prevalent vector-borne disease in the world. Despite the considerable advances in the understanding of the pathophysiology of the disease, dengue remains a significant challenge to doctors worldwide due to lack of the specific treatment. Therefore, improving the management of the dengue and severe dengue in ICU is the crucial to reduce mortality and mortality. Regarding the flavivirus belonging to the Flaviviridae family. It has a four serotypes with the human repercussions, and fifth serotype was described in 2007, which is restricted to the sylvactic cycle. Now, regarding the infection. During feeding of infected female mosquito, dengue virus is inoculated into skin tissue and introduced into the bloodstream. Once in the skin, the virus infects various immune cells such as macrophages, dendritic cell, and Langerhans cell. These infected cells then migrate to the lymph node where they come in contact with new cells and initiate new infection leading to the virus. So the intrinsic incubation period of dengue virus, that is the time period between the mosquito bite and the onset of symptom, is typically 3 to 10 days. The binding of E protein with specific receptor lead to the fusion of viral and host cell membrane, allowing virus to enter the cell. After endocytosis, the new viral nucleocapsid is released and single-stranded RNA is translated into polyprotein that is cleaved by non-structural proteins NS2B and NS3. The transcription process then begins at the replication site on endoplasmic reticulum. Meanwhile, the NS1 protein are produced and released from the host cell, mediating a series of reactions that induces cytokine inflammatory response. This finding corresponds to the first clinical phase of dengue infection, known as febrile phase. After this phase, the patient evolved into critical phase. Regarding cytokine storm, the antibody-dependent enhancement phenomenon is widely regarded as most significant factor contributing to severe dengue disease. When large amount of virus invades the host cell, the strong response from newly infected cell activates multiple inflammatory cascades. Meanwhile, a weak cross-reaction between previously activated T cell and new serotype infection induces the production of pro-inflammatory cytokines such as interferon alpha, beta, and gamma. This cytokine release is further aggravated by NS1, which, along with non-neutralizing antibody, stimulate the release of NF kappa beta, ultimately resulting in cytokine storm. Regarding vascular permeability, dengue vascular permeability syndrome, previously known as dengue hemorrhagic fever and dengue shock syndrome, is complex and multifactorial condition associated with capillary permeability, plasma leakage, potentially leading to severe disease. Several hypotheses has been proposed to explain the mechanism of this permeability. Hypotheses involve the direct infection of endothelial cell, causing their apoptosis, cytokine storm, eventually activating several pathways, inducing plasma leakage. Moreover, immune-mediated mechanisms have been proposed involving the formation of complexes between dengue virus and antibody. These complexes activates the complement, reducing the level of C3, increasing the level of C3A and C5A anaphylotoxin. These anaphylotoxins act at endothelial surface and contribute to vascular leakage. The NS1 protein also contribute to vascular permeability. Another mechanism of vascular permeability in dengue involves platelet activation. Other factors that may influence the vascular permeability in dengue include mast cell activation, platelet activating factor excretion, the angiopoietin 1 and 2 ratio, bradykinin, and prostacyclins. Regarding thrombocytopenia coagulopathy, the multifactorial etiology of thrombocytopenia and dengue fever include early stage bone marrow megakaryocyte suppression, peripheral disruption of platelet due to antibody-mediated lysis, increased platelet consumption due to adherence to damaged endothelial cell and subsequent lysis. Patients with severe dengue usually have decreased protein S, protein C level, and significant increased level of plasminogen activating inhibitor 1 level. These findings correlate with the worse outcome, which may reflect the imbalance between procoagulant and fibrinolytic mechanism. Most patients recover spontaneously from this lab abnormality during convalescent stage. Now, factors associated with severe dengue. Host factors like age, female sex, pregnancy, immunocompromised patient, diabetes mellitus, obesity, subnutritional status, and asthma. Genetic factors like non-African ancestry, genetic polymorphism such as HLA class 1, FC gamma receptor, tumor necrosis factor alpha, ICAM3 grabbing non-integrins, that one, CTLA4, vitamin D receptor, human platelet antigen, transporter associated antigen processing, and TGF beta. Immunological status like previous dengue infection, timing between first and second infection, previous exposure to the other flavivirus. Then regarding viral strain, infection with dengue virus serotype, genotype, and magnitude of virus. Regarding warning signs and severity classification, in 2009, WHO introduced new classification for dengue case, replacing the previous term, that is dengue hemorrhagic fever and dengue shock syndrome with dengue with or without warning sign and severe dengue. Warning sign introduced in 2009 classification have proved to be valuable tool for predicting patient with increased risk of disease progression. Although individual warning signs have low positive predictive value, their combination yield high accuracy and should be used for close monitoring. Recent studies have identified potential markers that could be added to this list to improve accuracy. These include clinical signs in the early stage of the disease, such as altered mental status, tachycardia, pleural effusion, ascites, biomarkers such as elevated total bilirubin, aspartate aminotransferase, align aminotransferase level, and decreasing albumin level. Severe dengue is defined as severe plasma leakage in patient leading to shock, defined as tachycardia, narrowing of pulse pressure, delayed capillary filling, hypotension, pulmonary fluid accumulation with respiratory distress, severe bleeding, severe organ involvement, especially central nervous system, liver, and heart. Regarding diagnostic approach, specific diagnostic tests for dengue depend upon the patient's clinical phase. In the initial febrile phase, during first 5 days of disease, tests to detect virus and antigen are recommended. Detection of NS1 antigen in the blood sample by enzyme-linked immunosorbent assay and rapid immunochromatographic assay are simple and low-cost tests for clinical settings, with high specificity and sensitivity that varies according to the commercially available test. NS1 antigen can be detected in sera until 9th day of symptom and during primary infection and until 7th day during secondary infection. Direct nucleic acid amplification in human sample can detect the dengue RNA as early as 24 to 48 hours before symptom through reverse transcriptase polymerase chain reaction, real-time RT-PCR, and isothermal amplification method. These tests retain high sensitivity, that is 80 to 100%, and specificity 99 to 100%. After day 5 of disease, specific antibodies appear and could be detected by serological test, even though dengue RNA and antigen could still be present. This test include hemagglutination inhibition, ELISA to detect IgM, IgG. ELISA-based method is widely used in developing country due to its relative simplicity, lower cost, and associated with high sensitivity 90% and specificity 98%. Primary infection, IgM can be detected in serum sample as early as 4 days. Its rate increase until day 6 and remain positive for several months. Meanwhile, IgG starts to increase after the recovery. In secondary infection, IgM level could be undetectable while IgG titers rapidly increase as early as day 3. Due to this variation, the WHO recommended diagnosis of dengue can only be confirmed when there is evidence of seroconversion from IgM to IgG or fourfold increase in IgG titer in paired serum. In endemic areas where there is a transmission of flavivirus such as Zika virus, chikungunya virus, yellow fever virus, differential diagnosis could be challenging because clinical manifestations are similar and serological tests could cross-react with previous infection or vaccination. In such a cases, molecular diagnosis with RT-PCR is recommended if possible. If the only evidence of the dengue is positive, anti-dengue NV IgM test, a plaque reduction neutralization test can be performed to quantify virus-specific antibody titer and confirm the diagnosis. However, this test is readily available in clinical lab. Viral isolation, when dengue is isolated after inoculation of clinical specimens such as whole blood and tissue and into cell line, is the most specific test. However, its applicability is limited by cost and it requires specific lab with well-trained person and time. The window period of sample collection is short and depend on the level of viremia. The test requires at least 7 days. However, its use is reserved for the research purpose. Regarding complementary approach, in overall assessment of the patient with suspected and confirmed dengue, WHO recommended conducting routine lab tests. In facilities where it is available, full blood count should be performed at first visit and repeated daily and at least after third and fifth day of symptom. Establishing baseline hematocrit level in early febrile phase is crucial and any subsequent rise can suggest plasma leakage. Leukopenia often accompanied by increasing atypical lymphocytes. Thrombocytopenia are very common and precedes the critical phase. Neutropenia may also occur, although it is not typically associated with secondary bacterial infection. Prophylactic antibiotics are therefore not. Elevated transaminases and hypoalbuminemia may be present, reflecting liver involvement and predicting potential severe progression. An increase in serum creatinine kinase often occurs and could be the marker of myositis. Vascular leakage usually preferentially occur in pleural and peritoneal space. Therefore, early assessment using point-of-care ultrasound to detect pleural effusion, gallbladder wall edema, ascites, and pericholecystic fluid collection is recommended. Regarding general management, the cornerstone for the management of the dengue is supportive care, early recognition of warning signs. During febrile phase, the treating symptom with rest, antipyretic, and hydration is sufficient. Every patient must be instructed regarding the warning sign and the critical phase that could follow differences. Patient with the risk factor for severe disease must be closely followed. Acetaminophen and metamizole are preferable drug for temperature control considering their safety profile. NSAID and acetyl salicylic acid must be avoided due to their increased risk of GI bleed and dry skin. Due to inflammatory aspect of the disease, the use of corticosteroid in dengue infection was always considered in the management of the severe cases. Some articles in 1917 and 1980 found some reduction in mortality, but since then, several studies have failed to demonstrate the benefit of using corticosteroid in dengue infection, even in most severe cases. In 2014, concurrent review showed no significant reduction in progression to severe disease, bleeding, severe thrombocytopenia, and mortality. Therefore, the WHO contradicts the use of corticosteroid in dengue infection. More randomized controlled trials are needed to better address this issue. Now, regarding management of the plasma leakage, and plasma leakage is the main mechanism of dengue shock and probably the greatest concern in severe dengue. Around the time of differences, the patient may experience worsening symptoms and increased capillary permeability. Volume restitution is needed to prevent and reverse hypovolemic shock. Oral rehydration may be sufficient in patients without warning signs who tolerate oral fluid intake. However, patients who do not tolerate oral fluid intake experience persistent increase in hematocrit despite oral hydration or present warning signs should receive intravenous fluid. According to WHO recommendations for clinical management of dengue, patients with severe dengue should be promptly admitted to ICU and receive fluid expansion. No benefit or distinction in clinical improvement was found with the use of colloid infusion over crystalloid. Therefore, initial fluid expansion with crystalloid is suitable. The intravenous colloid solution is warranted in intractable shock resistant to first resuscitation. Fluid resuscitation should be guided by clinical parameters to improve central and peripheral circulation, characterized by decrease of tachycardia, improvement blood pressure, pulse volume, return of capillary refill time to less than 3 seconds, improvement in the level of consciousness, urine output more than or equal to 0.5 ml per kg per hour, and decreasing metabolic acidosis. Hematocrit measurements may help in assessing fluid responsiveness. When hematocrit decline without clinical improvement or maintenance of hypovolemic shock, occult bleeding must be investigated. The first 24 to 48 hours of plasma leakage are crucial and patient may develop recurrent shock during this period. The unique dynamism of this condition require close medical observation, sequential evaluation to guarantee the proper recovery of hemodynamic stability. Intravenous fluid should be then weaned gradually after improvement of perfusion parameters. The infusion rate of fluid administration should be progressively reduced over 24 to 48 hours following plasma leakage. With proper treatment, most patients will recover in few days. Management of thrombocytopenia and hemorrhage. Bleeding manifestations are common in dengue, affecting approximately 20% to 60% of hospitalized patients. With mucocutaneous bleeding is often mild, severe hemorrhage and gastrointestinal, gynecological, pulmonary system may occur, leading to fatal outcome. Interestingly, several studies have reported weak correlation of thrombocytopenia and coagulation abnormalities with incidence and severity of bleeding. Furthermore, the duration of the shock is one of the main risk factors for severe hemorrhage in patients with severe dengue. Efforts to close monitor the hematocrit and vigorous intravenous therapy may be crucial to reduce blood product usage and shorten hospital stay. Regarding prophylactic platelet transfusion, the thrombocytopenia is fairly common and benefit of prophylactic platelet transfusion has been a matter of interest in several research. However, randomized RCT evaluating the role of transfusion of non-bleeding or mildly bleeding patients with platelet count lower than 20,000 to 30,000 have failed to show significant reduction in progression to severe bleeding. So, conversely, transfusion-related adverse reactions such as circulatory overload and allergic reaction have been reported. Studies evaluating post-transfusion platelet increment found that non-responders were individuals with the low baseline platelet count. Authors hypothesize that immune-mediated destruction may be more pronounced in patients with the lower platelet count. Therefore, those more prone to receive platelet concentrate and may also be more likely to be poor responders not benefit from transfusion. Currently, there is no evidence supporting prophylactic platelet transfusion. However, more studies with sufficient power are needed to evaluate transfusion benefits in preventing severe bleeding at lower threshold, especially in patients with severe dengue. Now, transfusion and other agents for bleeding patients. Currently, there is no RCT evaluating the benefit of platelet transfusion for patients with significant bleeding manifestation. Additionally, immune-mediated platelet lysis may destroy the donor platelet. As a result, WHO suggests providing only fresh packed red cells and whole blood transfusion support for patients with significant hemorrhage. However, considering that contribution of immune-mediated platelet destruction may vary among individuals, and about half of the patients are PPI responders, it seems reasonable to consider platelet transfusion in case of persistent severe life-threatening bleeding with thrombocytopenia. Physicians should also be aware that because thrombocytopenia may not be the only cause of bleeding, it is important to evaluate and correct coagulation abnormalities with fresh frozen plasma, cryo, and vitamin K. There is currently insufficient evidence to support the routine use of other agents such as recombinantly activated factor A, IVIG, and anti-globulin. Specific and local measure to control bleeding may also be useful, such as intranasal packing, hemostatic sponges for epistaxis, hormonal method for menorrhagia. Unnecessarily invasive procedures should be avoided. It is important to note that plasma leakage leads to elevated hematocrit level above baseline value. Therefore, physicians should always suspect internal bleeding in cases of persistent and worsening shock despite hematocrit decrease. Providing RBC transfusion is also necessary to maintain adequate tissue oxygenation. Regarding organ dysfunction, several complications may aggravate patients with dengue fever, including fluid overload, bacterial infection, and organ dysfunction such as neurologic, hepatic, heart, kidney, lung, and hematologic impairment. Overload hydration during recovery phase, there is rapid resorption of the fluid that accumulate in the virtuous spaces due to plasma leakage, such as pleura and peritoneum. The discontinuation of the fluid supplementation in this phase is necessary to prevent hypervolemia and overload hydration. Excessive fluid administration can cause pulmonary edema and congestive heart. Bacterial co-infection is relatively uncommon but serious complication. While around 7% of patients with dengue present concurrent bacteremia, up to 44% of dengue-associated deaths are related to the bacterial co-infection. Primary bacteremia is the principal site of infection related to dengue fever, followed by pneumonia, bile duct infection, and urinary tract infection. Additionally, due to its high prevalence in tropical countries, other diseases such as leptospirosis, typhus, malaria, and trich fever should be considered in the management of the patient with severe dengue. Patients with the older age, acute renal failure, GI bleeding, prolonged fever, and altered level of consciousness have increased level risk of concurrent bacterial infection. The diagnosis of co-infection could be challenging due to overlapping symptoms. However, elevated leukocytes, C-reactive protein, lactate, as well as prolonged APTT, high acute physiology, chronic health evaluation score, that is Apache score, and therapeutic intervention scoring system, positive fluid balance are found in patients with bacterial co-infection. In addition, recent studies showed that PCT could be a helpful marker of bacterial co-infection. Though dengue is the neurotropic virus that can directly infect the supporting cells of the CNS, causing neuronal injury. So, some neurological symptoms are related to the inflammatory nature of the disease. Dengue can lead to plasma leakage, edematous swelling, dysregulated cytokine release, resulting in immune-mediated neural damage. The various neurological manifestations related to dengue fever is categorized into encephalopathy, encephalitis, immune-mediated syndrome, muscle dysfunction, dengue-associated stroke, and neuro-ophthalmic disorders. Dengue can directly infect the liver, cause apoptosis of hepatocytes, leading to classic finding of liver enzyme elevation. The increase in AST, ALT considered the markers of severe dengue. Cardiac involvement is considered as a rare complication, and the spectrum of cardiovascular manifestations in dengue infection is broad, ranging from subtle STT changes to permanent myocarditis. Kidney impairment in patients with dengue fever is mostly mild, ranging from serum electrolyte abnormality to hematuria and proteinuria. Patients that may develop renal damage may develop more severe complications such as AKI and hemolytic uremic syndrome. Pulmonary complications are rare, although upper airway symptoms may occur frequently. Patients with the dengue may experience various impairments in pulmonary system, including pleural effusion, non-cardiogenic pulmonary edema, pneumonitis, ARDS, pulmonary hemorrhage. Thrombocytopenia and disturbance in coagulation cascade are responsible for alveolar hemorrhage and hemoptysis. Hematological complications related to dengue infection are uncommon, including persistent low platelet count and HLH. Persistent thrombocytopenia is a rare complication after dengue infection. In the context of secondary immune thrombocytopenic purpura, it is defined as prolonged low count after recovery phase. The mechanism is still unknown, although persistent antiplatelet IgG may be found, suggesting immune platelet destruction. Due to its rarity, only case report can be found in the literature, and successful treatment has been published after the use of corticosteroid and IVH. Thank you, guys.